Coming to our next speaker is Dr. Andrew Burke. Andrew Burke is Associate Professor, recently got his PhD, and we're all very proud of him. Dual specialist in respiratory medicine and infectious diseases, and Director of Infectious Diseases at the Prince Charles Hospital. His research interests include the pharmacokinetics of mycobacteria treatment and mycobacterial clinical trials. He's the current chair of the Australian Clinical TB networks, and he's going to present another complex adult case.
Thanks, Kathy. So Holly mentioned the liver transplant patient, so I want to talk about that patient. And we've done three patients at Prince Charles have had phage therapy. So two have had cystic fibrosis. One is this patient who's also had a liver transplant, and the other was a mycobacterial abscessus patient. And grateful for Holly's team under the auspices of the STAMP study organised for mycobacterial abscessus phages from the Hatfield lab in Pittsburgh. So they've all been complicated in their own way. I'm going to focus on this one. So this is a 27-year-old male with cystic fibrosis, and he had a liver transplant, and he's got chronic, almost pan-resistant Pseudomonas aeruginosa. Just a bit of a crash course in cystic fibrosis. So the delta F508 is the most common allele. So if you're homozygous for that, you have the most typical phenotype. Some people also have, there's hundreds of alleles we now know about, and he had this delta 1507, but nevertheless had a severe phenotypic cystic fibrosis. And liver transplantation occurred at 6 years of age for him. And so for cystic fibrosis, they tend to get it's called a channelopathy. So they get viscous secretions in the biliary tract, and they get like a primary biliary cirrhosis type of process. So quite a number of patients go on to have a liver transplant, even though their lungs might be relatively okay. And so traditionally that's been the case in children more so than adults. So it tends to sort of peak around that, probably around this age, late sort of 6 to 10 years of age. Although those patients have lived longer now, there's been a second peak in their 30s and 40s. And he also had cystic fibrosis-related diabetes and pancreatic insufficiency. Our CF colleagues are very conservative in terms of doing CT scans. So the most recent CT scan I could find was about 8 years ago, 2017. It tends not to change management, and they try to minimise radiation. So it's a classic bronchiectasis type there. So many of you appreciate aren't cystic fibrosis specialists, but you may have heard about these new drugs, which have been around since about 2022 in Australia. So we call them CAFTAs for short. So there's the three drugs that we incorporate into Trikafta. And they've really transformed cystic fibrosis medicine in the same way that Professor Wolf spoke about HIV therapy. Many of us started infectious disease because we're interested in HIV/AIDS, and now that's really almost, it's very rare in the Australian context. And the same thing has transformed cystic fibrosis care. One of the things is about 10% of our CF patients probably can't take it because of hepatotoxicity or some other side effects. Sort of a rough number. He did start it. He got significant hepatotoxicity, and although his sweat chloride had come down to sort of almost normal at 40, it sort of rebounded once that was ceased. And he had almost pan-resistant Pseudomonas aeruginosa. It was resistant to all the beta-lactams. It was susceptible to colistin and aminoglycosides. One other thing about this young man is that he got significant hepatotoxicity every time he got beta-lactam. So oftentimes it says resistance, but the CF physicians use those drugs anyway, based on some literature that said that biograms often don't predict treatment response in CF-related bronchiectasis. But every time he had an admission, his LFT would go up to 500 or so, okay? Ever since his liver transplant. And he had phage therapy in August 2024, and really had quite deteriorating health in the 12 months prior to that. And we'd had one other patient with cystic fibrosis have phage therapy for the STAMP study, who wasn't a transplant candidate, and he subjectively had a very good response in that he went from about 3 months of admissions a year to about 1 to 2 weeks, although that was, as Holly alluded to, that was not maintained, that benefit. So he was really quite a frail fellow, and we enrolled him into the STAMP study. And so just so that you know how that process works, I've had the good fortune of knowing Holly now, so it's nice when you can sort of phone a friend who knows involved in this. But it took about 4 weeks to get a phage sent to us, which I think is quite remarkable. So we would send the Pseudomonas isolate, and Pathology Queensland here have been very helpful in terms of keeping those isolates. If we think somebody may need phage therapy, we ask them to sort of hold the Pseudomonas isolate. The colleagues in Westmead want as many sort of Pseudomonas isolates as possible, because even though the biograms may look the same, on sequencing, they may be different. So we sent down a number of strains, I think 3 strains of Pseudomonas, or 3 isolates of Pseudomonas, I should say, for this fellow. And there was 2 matches, which I'll show in a moment. And it was great. Both Holly and Adam have sort of shown these slides. This is Pseudomonas strain number 3, but essentially they all had very similar pharmacokinetics. Again, as I know, also learning about this for the first time often today, but the screen is when there's no phage exposure. And then there was 2 different phages that were used. So again, like Adam's case, it was a cocktail, so PAE 200 and PAE 202. And you can see there's been like some phage activity there. Now, this fellow's problem is that you might remember every time he gets beta-lactams, his ALT, AST go through the roof. And the same thing happened with his phages. So if you look at having looked at a review article recently of phage therapy for bronchiectasis, most people in Europe seem to be using nebulized phages. In discussion with our colleagues in Westmead, they said, look, we can provide IV as well. None of us know whether IV adds value. Keeping in mind there's this self-propagation of phages anyway. So we don't know how many doses to give. Is IV or nebulized better? So we gave both. And basically we would give once daily for 2 days and then go up to sort of twice daily for both IV and nebulized. But these lines here are really all reflecting his liver function test. So you can see as soon as he had IV and nebulized phages, his transaminases and cholestatic picture went off. He didn't have normal baseline function, and he's actually in hospital at the moment. He had a PEG change last week, and again, even just changing the PEG, his ALT went up to 500. So he's got a very sensitive liver. Obviously, the decision to give phages was made in conjunction with his liver transplant team, who are based at Princess Alexandra Hospital. So we, after speaking to them, and the CF team were a bit nervous, obviously, we withheld his phages for a period of time and then decided just to go to nebulized phages, thinking that may avoid systemic phage replication and perhaps prevent hepatotoxicity, but the same thing occurred again with nebulized phages. So he had an MRCP quite early, even on day 3 of his phage therapy, he had an MRCP which was normal. There's some treatment interruption there. And just to go through, to orientate you to this slide, so part of the protocol is measuring plaque-forming units, and I'll show you a slide in a moment, which Adam has already shown. So these are good. This tells you that the phage is working, that there's it's a target-rich environment. They've got Pseudomonas and they're replicating. And on these lines here are really looking at the PCR equivalent to what Holly described. So looking at phage replication, which is ongoing. And so again, just more for my own benefit, we're just seeing how we have quantitative and semi-quantitative measures of phage activity. It's a little bit like, again, as a non-microbiologist, we have the disc susceptibility testing where you get a little zone of inhibition. The same thing happens with phages, and we can call those plaques. And Adam had a slide from his own patient, which I don't have, but the same sort of thing applies where we're trying to look at the number of plaques, and that's a surrogate marker for phage activity. This is again just looking at sort of the same slide, and the bottom line here is actually his AST. And I guess the point of this is to show you that when his phages were high, both in the sputum and the serum, his liver function went worse. So we stopped phages, they went away, liver function tests normalized, and it got worse again when we re-challenged him. And as a result of that, we decided to stop all phage therapy. This is another way of measuring susceptibility. So you'll hear about this term EOP, or efficiency of plating. Again, it's looking at the plaque-forming units. And I guess the grey line down here is, if you like, the reference standard. So 1 is really sort of 100% efficiency, if you like. And you can sort of see here between 0.1 and 1. I mean, these are all new to me until I've met these patients. And thank you also to Holly's team. Holly provided this slide for me. These are the 2 different strains. You can see that even on day 43, the still susceptible phages are isolated. So there's no phage resistance, if you like. So just in summary for this fellow, it was an SAE, and I looked at the literature and I couldn't find any other evidence of LFT, of hepatotoxicity with phages. Having said that, his liver is obviously primed to being very vulnerable to hepatotoxicity, so with beta-lactam antibiotics, PEG changes, and what have you. So in some ways, it wasn't a surprise. Our CF physicians are quite sober-minded and are quite conservative, but they felt that for both of our patients with CF, even though they didn't eradicate their Pseudomonas, they felt strongly that there was an improvement. certainly over 6 to 12 months, that there was a significant decrease in hospitalizations for these patients, but it wasn't maintained after 12 months. And it raised the question then, and I've spoken about to Holly and her team about whether they should be retreating these patients. I guess that's a whole other question. And Holly, in that other review article, she actually had these 2 patients down the bottom. So 2 other liver transplant patients I could find who had phage therapy. They're both children. And they were both really done early because of early post-transplant complications. So they'd had anastomach leak, peritonitis, hepatic abscesses. The first patient, I think, was only about a year of age. And they gave 3 months of phage therapy. The surgeons put phage into the peritoneal cavity when they were draining these abscesses and mixed it all around. And they were able to get the child well enough for a retransplantation, which was successful. And the other child had Enterococcus faecium as well. So they're the only 2 other liver transplantation cases I could find in the literature. So just to acknowledge, these are the people I've emailed, but as Holly and Adam have shown, there's a very big team behind Phage Australia. I should just give a plug to, they had a great one-day symposium at Westmead late last year, and hopefully it'll be repeated. It was a hybrid meeting, and so I learned a lot. So look forward to the discussion. Thank you.